if we intervene at the right time for the right candidate, it also can be game changing. Maybe they were going to go into heart failure within the year, but now maybe we're setting that clock back by a year or two. We can't yet speak to efficacy until we have that longer term data, but that is kind of our goal, is giving them more quality time with their pet.
Hey, Vetfolio Voice friends, I'm glad you're here. This episode is sponsored by Boehringer Ingelheim Animal Health and features Dr. Brianna Potter, here to offer her insight into the diagnostic approach in the case of a dog with a newly diagnosed heart murmur. Heart murmurs are certainly not an uncommon finding, and oftentimes they're diagnosed during these so-called routine exams. However, despite the fact that we frequently encounter murmurs in practice, recommendations about how and when to pursue a full workup can be a bit more nuanced. In our conversation here, we discussed how different factors like the age of the dog, the murmur's location, its intensity, can help us narrow down the possible causes of the murmur. And we also tried to shed light on the pros and cons of different diagnostic approaches and tests, such as when it might be reasonable to rely on radiographs alone, or when it's more beneficial or even necessary to recommend a patient pursue an echocardiogram or a proBNP in addition to x-rays. We also reviewed the pharmacology of pimobendan and how the findings of the EPIC trial have influenced our recommendations on when to start this medication in a patient who may appear otherwise asymptomatic. And for those interested in the latest advancements in veterinary medicine, we most certainly talked about some of the cutting-edge open heart cardiac procedures now available for treating mitral valve disease in dogs. So whether you're just starting out or you've been in practice for years, I think you'll find today's episode both insightful and practical. Let me tell you a little bit more about Dr. Potter, and let's go ahead and dive in. Dr. Potter is originally from San Diego, California. She completed her veterinary degree at the University of Tennessee, then completed a rotating internship at The Ohio State University, followed by a cardiology residency and 2-year interventional cardiac fellowship at Colorado State University. She's a diplomate of the American College of Veterinary Internal Medicine and Cardiology and is currently an assistant professor at Colorado State University. Her interests include interventional therapies for congenital and acquired heart disease and advanced imaging. When she's not at work, she enjoys spending time outside hiking, skiing, and camping, as anyone who lives in Colorado I'm sure should. Gosh, it's beautiful out there. Okay, let's go ahead and get into our episode.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
All right, I'm really excited for this episode where I'm joined by Dr. Brianna Potter, and we're going to talk cardiology. And oh my goodness, so much happening in the field of cardiology recently. And I know personally, I'm hoping I'm reflective of our audience out there. I think I am. I have questions. So thank you so much for joining me.
Absolutely. Thanks for having me.
Yes, and I'm really excited to dive into this because we're going to talk about the approach to a new murmur and a lot of questions that I know come up for me in general practice when I'm thinking about a new murmur. So yeah, hopefully we can get some information out there to everybody else out there who has these questions.
Absolutely.
Well, let's start with just that question itself. I'm wondering your recommendations for the approach to a new murmur. I'm guessing that probably being a cardiologist, these aren't the cases that you're seeing regularly, but you're probably getting a lot of phone calls from people like me who have that new murmur and we're going, where do we go next?
Every patient that is coming into your practice, you want to take a good listen. I think if you auscult a new murmur, I would keep in mind kind of a few things, signalment of the patient. So if it is a younger dog or cat, are you more worried about, maybe your mind goes more towards maybe congenital heart disease. I think if it's a older patient, that's small breed, that's definitely when kind of mitral valve disease, my suspicion of mitral valve disease gets a little bit higher. I think the larger breed dog that's older, potentially you are thinking more, could this be dilated cardiomyopathy? And so today's episode will kind of focus more on the older small breed dog. But I think, if that older small breed dog presents to you, you hear a new heart murmur. Another thing I wanted to mention was just kind of location as well and timing of the murmur. And so that murmur should be more at the left apex and then should be systolic in timing. So I know that, timing of murmurs can be a little challenging sometimes, but really left apical systolic, if you take a really good listen. And then my suspicion of, potentially other disease processes would increase if it was away from that region. So if it's more at the left base, or I think another thing to keep in mind is if the patient is very systemically ill, could that new left apical systolic murmur be more suspicion of endocarditis or something like that? And so really, if it's systemically well, comes to you kind of for a wellness exam, you hear that new left apical systolic murmur, then my suspicion for mitral valve disease increases for that patient.
And I'm glad that we're talking about this because I'm just thinking of my own kind of biased mentality when I approach these cases. It can be really easy to sort of default to mitral valve disease when you hear that new murmur in an older patient. You're like, oh, must be mitral valve
Yeah.
disease. So it's a good reminder to really localize that murmur, figure out the timing, and make sure that that makes sense with your clinical picture.
Yes. And then another thing I want to mention for these murmurs is really the grading can also be helpful. So if it is a more quiet murmur, so kind of grade 1 through 6, if it's more on the quiet side, this roughly can correlate to kind of the severity of that leak of the mitral valve. And so we'll talk later too, just about kind of how to use this information in kind of staging these patients. But I do think thankfully you can use that as a little bit of an indicator of, if you never heard it before and now you're hearing a grade 5 or 6, then potentially, your suspicion for mitral valve disease and wanting to stage it is maybe even a little higher.
Okay, I'm glad that you said that because the grading of the murmur has been one of those things I know I've struggled with. I think of like the finger over the hose analogy that our cardiology professor, at least they taught me in school, where, the smaller the hole, the more force, so you can have a louder murmur. But when I actually think about that in an older patient with a new murmur, thinking, MMVD, mitral valve disease, very common, I'm going that hose over the finger analogy doesn't necessarily make sense. In my head, it makes more sense that the quieter the murmur, the smaller the leak. And so that would correlate to a degree with severity. And I would never hang my hat on that, but it does kind of influence my clinical recommendations. Whereas in a younger patient, the grading, if it's a loud murmur, I don't always think, oh, this is a more severe disease. I mean, I definitely, if in a young patient with a murmur, I'm like, we need to figure out what this is because we can't have this in the long term. But in these older patients, that's kind of where my brain goes. So it's nice to know that there is some degree of correlation there.
Yeah, and I think it very much depends on the disease process. So you're very much right. In the young dog with where you're suspicious of congenital heart disease, in a defect like a VSD or ventricular septal defect, you do almost want it to be louder because that means that the hole is smaller. Whereas, so I think that's a little bit probably important to just think about what is the disease process. And in the congenital heart diseases, they don't always follow that, where quieter, more benign, louder, more pathologic. I think in the mitral valve disease patient, though, you can kind of keep that rule of thumb.
I'm going to just put that, in my hip pocket and hold on to that for my exams.
Perfect.
And I won't, I promise I won't, make any hard and fast determinations with it, but it is kind of a good nugget to keep in mind.
Yeah, of course.
And then, of course, we had this amazing study a few years back, the EPIC study, showing that giving pemobendin early in the disease process can have a major influence in longevity in these patients with mitral valve disease. So I keep that in my head. I go, okay, pemobendin and mitral valve disease. But I would love it if you would just kind of review pemobendin for us and why it's important. What are the pharmacokinetics? What's it doing in the heart of these cardiac patients?
Yeah, so pemobendin for us, as you alluded to, has been just game changing for veterinary cardiology. Pemobendin is going to have kind of two main functions. So one is a calcium sensitizing function. So that's going to just sensitize the cardiomyocyte to calcium, and that's going to help strengthen the bond really during contraction of the cardiac troponin and different mechanisms of the myofibril. And so that's going to be a positive inotrope. So you can kind of think of that as the calcium sensitizing effect. And then the other effect is that it's a phosphodiesterase 3 inhibitor, which is a mouthful. But what that does is it's going to cause vasodilation of your systemic arterioles. And so why that's helpful is that you're going to decrease the afterload on the heart. And so really in these kind of what I explained to owners too is we're not only helping with inotropic or contractility of the heart, but we're also helping to kind of vasodilate to make it easier for us to have kind of forward cardiac output out of the heart. And so that's very helpful in a disease process where we're dealing with a volume overload. A lot of their blood, with each contraction, this with the stroke volume, a lot of that blood flow is going backwards in mitral valve regurgitation. So kind of nice to vasodilate and help with positive inotropy.
That makes sense that the blood's going to follow the path of least resistance. So if we can
Yeah.
vasodilate systemically, then that path of least resistance is going to be taking that blood out into the body where it's supposed to go instead of backflowing into the lungs and into the pulmonary vasculature. Does pemobendin have that vasodilatory effect on the pulmonary vasculature as well, or just the systemic vasculature?
Mainly systemic. There has been, people looking into its use in like cases of pulmonary hypertension, which you could consider giving that, like if there was reduced right heart function, kind of for that inotropic effect. However, it really just hasn't been looked into in depth. So I would say when you're thinking about pemobendin and kind of what we know that it's labeled for is going to be for mitral valve disease and more systemic arterial effects.
That makes sense. That makes sense. And if you were to administer it with right heart disease, you're really focused on that inotropic effect.
Right.
Well, let's talk about staging. Thinking of it from a general practice standpoint, this can create some challenges if maybe we're working with some tests, but not all of them, and we're having to piece the information together. But it's important because when we're talking about pemobendin and the EPIC study, when it comes to mitral valve disease, there's a clear indication of kind of when to start, when that pemobendin is indicated. So, can you review for us the staging system for heart disease and how we make that determination on when to start pemobendin?
Yeah, absolutely. So, quick overview on the ACVIM staging. So, we have a consensus group that put together a staging system. Stage A is going to just be your kind of at-risk population. So, the poster child, unfortunately, because they're such wonderful dogs, are the Cavalier King Charles Spaniel. So, they're going to be, if they don't have any heart murmur or any evidence of disease, they would kind of be in that stage A. So, just at risk. There are other breeds of these kind of smaller breed dogs that will also be at risk. The Chihuahua, the Dachshund, Shih Tzus, those types of breeds. So going into stage B, you'll have stage B1 and then stage B2. And now these patients will have a heart murmur. They also, on echo, you would diagnose them with mitral regurgitation and disease of that valve, but they don't yet have symptoms of heart failure. So that is the line in the sand, as stage C would be a patient diagnosed with congestive heart failure. And then stage D is going to be the more refractory heart failure patients. And so then, as you had alluded to, kind of stage B1 and B2 can be a little challenging, I think, in your practice to decide how do we stage them with the diagnostics that you have. And so I think for me, diagnostics that can be very helpful. One is your ear. So the patients that were included in the EPIC study all had grade 3 or 3 out of 6 murmurs or greater. And I wouldn't diagnose the stage just by the murmur alone, but using that as a piece of information in your kind of toolbox. I think chest radiographs or thoracic radiographs are probably the most helpful for someone that doesn't have access to echo. And so in those patients, kind of, I think it can be confusing, kind of where is that line in the sand? But I think doing thoracic rads and really getting objective measurements of heart enlargement can be very helpful. So why we care so much between this stage B1 and B2 is going to be, do they have significant heart enlargement enough to warrant the use of pemobendin? And that's kind of where this EPIC trial has been so helpful and kind of giving us that guidance. And so for that, those objective measurements you want to look at will include both the vertebral heart score as well as the vertebral left atrial score. And so those two measurements are objective, and there are different resources out there to kind of refresh your memory if you aren't quite sure of how to measure those. I can go over it very briefly, but for the VHS, you're going to get an idea of kind of, is there global kind of cardiomegaly. So it's not going to give you specific information on is there left heart enlargement or right heart enlargement, but just is there cardiomegaly or not. And so what I would recommend there is to perform the vertebral heart score is you draw two lines over the cardiac silhouette in ideally a right lateral radiograph. But what I caution you is only measure the VHS and the VLAS on a radiograph that's straight. So if it's obliqued, that's going to make it more challenging to measure that. In terms of the VHS, kind of measuring from the ventral border of the carina in right lateral recumbency, and then extending that line down to the apex of the heart, kind of following the longest portion of the heart. And then the second line will be across the heart in the widest portion, and it should be 90 degrees from the first line. And then you're going to take both of those lines and then start at the fourth vertebral body, the cranial portion, and measure those two lines out, and then actually count the vertebral bodies to get this number. So you're going to add those two numbers together. And then normal is going to be less than around 10.7. And I should caution you that can be breed specific. So there are actually like breed specific reference ranges. And then when we talk about kind of what makes a B2 patient B2, it would really be most likely in a patient with a VHS greater than 11.5. So using that number, I think, can be very helpful. And then for kind of reviewing that VLAS measurement, it is a measurement from, again, the ventral border of the carina, and then kind of following it over to where the caudal border of the left atrium meets the cranial border of the caudal vena cava. And then it's just going to be that one line that you bring up to the beginning of the fourth vertebral body and measure that. And then normal for that should be less than 2.3. And then if for B2, really, if that is greater than 3, that would be much higher, a suspicion of stage B2.
I feel like 11.5. I haven't done a lot of VLAS scores. I've seen the technique, but I think I forget about it when I'm looking at these x-rays. So that's a great reminder to make sure that we're using that measurement. I do, however, make it a point to do vertebral heart scores when I'm suspicious of heart disease. I feel like 11.5 seems like a pretty big heart.
Yeah, I think for kind of the consensus of when to start pemobendin, I think what we wouldn't want is to start these dogs prematurely on it and have, because a lot of these dogs can be in stage B for quite a bit of time. And so I think having the owner, justifying having them give a more expensive medication when they may not need it. So I think the gold standard for the EPIC study was using echo, chest rads, and the murmur grade. And so doing echo, it might be more sensitive to kind of when we could catch those B2 patients. But I think for ease of making sure that we're kind of not starting it too early when they may not meet EPIC criteria, that's kind of where that 11.5. But you're right. Yeah, you could be waiting a while, kind of serially watching them, and that's okay.
Sure, sure. And, thinking just of practicing with any disease process, it seems like we have to make sure that we're treating our patients individually. And if we have, this patient who's older and this murmur is getting louder and louder and louder,
Yeah.
but we're like, well, it's not 11.5 yet, but we don't have any other diagnostics. It sounds like really taking these patients into account individually and their own nuances. If we were to start that drug prematurely, aside from the expense, because it can be a little bit pricey, are there negative impacts to our patients if, we got that clinical impression of like, hey, I really think I should start Pemo in this patient, the owner's declining an echo, and, kind of our spidey senses are tingling. Can we hurt our patients by starting it too early?
It is overall a very safe drug, which I think is great. We have the EPIC trial, which is amazing because it gives us kind of that data in that specific population. I think we haven't studied giving pemobendin to, normal dog or, stage B1 at least. And so I think without that information, I can't say for sure whether there's not harmful effects, but I'd say overall, if kind of using the murmur grade, maybe, if you did a bunch of measurements and you're kind of averaging very close to 11.5 and, the VLAS is also elevated or increased, I would use your best clinical judgment, but I don't think there's going to be overt harmful effects if it started a little bit early. But best recommendation from kind of that label are those cutoffs.
Sure, sure. And I'm glad to have those cutoffs for sure because that's always a debate I have is, at what point do we start this? Because I don't want to wait too long and end up with a patient in overt heart failure, but also I don't want to give this patient an unnecessary drug, give this owner an unnecessary expense and kind of start that clock ticking in before we even need to have that discussion.
Yeah, and I think another helpful thing would be, like you were mentioning, this dog that the murmur grade's getting more intense, and then you're watching them closely. I think to give the owner the peace of mind, you could say, hey, they're really not fitting the cutoff today. Maybe instead of seeing you in 6 months or, 9 months, let's see you a little bit earlier, 4 months or something like that. And that for someone that is motivated, but maybe access to echo is not available in your area. I think that could be another tool is just the serial monitoring at little closer intervals as well.
Absolutely. Absolutely. I think I'd like to talk about echocardiogram a little bit more because I love when I have an echocardiogram and I am fortunate that to have a lot of owners who are willing to pursue an echocardiogram and oh my gosh, it just completes the picture
Right.
when we're looking at heart disease to say, okay, now we really know what we've got on our hands here. So I'd love to hear in your words the benefits of pursuing an echocardiogram as opposed to just doing x-rays in these patients.
Yeah. Especially for, like you mentioned, those dogs that maybe they have a louder murmur, but they aren't fitting those, maybe they're just been hovering around VHS of like 11 to 11.5. I think where echo can be very beneficial is that we can do precise measurements of the left atrial size and the left ventricular size to really see if the precise cutoffs that the EPIC trial set. Maybe on RADs, they're not fitting that overt 11.5, but maybe we are fitting it with echo. So for that kind of borderline patient for you on x-rays, I think it could give you more information on, do they fit the EPIC criteria? It can help, we're going to get the definitive diagnosis of degenerative valve disease. So another population that it might be really helpful in are, say you have more of like a medium size dog. So maybe they're not fitting that like Chihuahua size, but they're 15 kilogram mixed breed dog and patient has a left apical systolic murmur. I think an echo can be very helpful to say, okay, yes, this is degenerative valve disease, or is something else going on? Does this dog have evidence of dilated cardiomyopathy or whatever it is? So getting you that real information on the systolic function and what's going on with the valve. We didn't talk about it too much in the murmur portion, but if you do have that kind of medium-sized dog, usually if that patient did have dilated cardiomyopathy, usually those left apical systolic murmurs are a little bit quieter. So you can kind of use that in your toolbox. And the reason for that is that as that heart dilates, it's not actually an issue with the mitral valve. It's just causing those leaflets to separate where then you do have mitral valve regurgitation, but it's more secondary, if that makes sense. So yes, getting the diagnosis and then in my world, because I live at altitude, pulmonary hypertension can be kind of the majority of the issue of why that patient's presenting clinically, or some dogs that live at altitude here, I see them with both mitral valve disease and pulmonary hypertension. So I think echo kind of wins out on giving you that information as well.
That makes sense. Are there any radiographic findings that can point us towards pulmonary hypertension if it's not like just incredibly dramatic vascular pattern?
Great question. I think for me, what I look at is say your VHS, so vertebral heart score is elevated, so you know there's cardiomegaly, especially in the like respiratory distress patient. If I have a VHS that's enlarged, but my VLAS is normal, like less than 2.3, then for me, at least living at altitude, I'm also looking at the lung pattern and kind of deciding, what could be the cause of the respiratory distress. But in that patient with the VLAS that's normal, my suspicion of left-sided heart failure is much lower. And then kind of keeping pulmonary hypertension on my list because that'll cause more right-sided enlargement, which would elevate your VHS, but kind of looking more for kind of increased sternal contact or kind of if you have a really straight radiograph, kind of that reverse D on the VD. So more right-sided characteristics. And then, yeah, the VLAS can be very helpful there because it kind of makes left-sided congestive heart failure less likely. And then the other thing I would say is sometimes their pulmonary, if you look at those cranial lobar vessels, the pulmonary artery is dilated more than in left-sided congestive heart failure. We're mainly looking at the pulmonary vein. So that can sometimes be a finding.
I like it. I like it. And I'm trying to do the pathophys in my head and follow blood do all of this, but you mentioned living at altitude. I live at sea level. I have my whole
Yeah.
life. I don't know if I would make it at altitude. What's the pathophysiology of the influence of altitude on pulmonary hypertension?
Yeah. So living at altitude, just with that lower oxygen content, it's just causing vasoconstriction of the pulmonary vasculature. And so it alone is not going to cause severe pulmonary hypertension. It's just going to be kind of a little additive factor. But then, yeah, in these small breed, this is why it's on our list here, is these small breed older dogs are one, the incidence of having also concurrent primary respiratory disease is high, right? Like they could have chronic bronchitis, they could have pulmonary fibrosis, they could also be coughing from tracheal collapse, things like that. So, having respiratory disease as a potential instigator of pulmonary hypertension, also the smaller old breed dog, if they have endocrine disease, they could be at higher risk for thromboembolic disease. And so we can see pulmonary thromboembolism. And so I'd say in the at altitude, we see some that they are handling their pulmonary hypertension at sea level, and then they'll like come up to see their like son or daughter at CSU and come to altitude, and then the dog can decompensate. So yeah, wouldn't be like the cause of them being in respiratory distress, but maybe just like a little bit of additive vasoconstriction.
One of these perpetuating factors.
Right.
Well, thank you for that. That was kind of an off the wall question, but when you
Yeah.
mentioned the altitude, I'm like, wait, how does it work? But that makes sense. So, like I said, fortunately, I'm lucky to have a fair number of pet owners who are willing to pursue an echocardiogram and we're able to complete that picture of heart disease and know what the indications are and how to monitor. But of course, I occasionally get that extremely financially constrained owner who just has all the best intentions in the world, but really can't do x-rays, can't do ECG, can't do echocardiogram. Do you have and I promise I won't hold you to them because I know this is it can get a little bit precarious. Do you have any recommendations on an approach to working up that heart disease and kind of knowing what to do with medications in those patients?
Yeah, I also am very lucky in my practice that I'm not seeing that population, but I know a lot of people are dealing with that scenario. So I think it's great to talk about. Like you said, we kind of walked through ideally we would have chest rads or echo, but I think a few things. I think one is watching the murmur grade. So I wouldn't be treating just on murmur alone, but kind of I think that serial information can be helpful for the patient and the pet owner. One additional tool that you may be able to use that we haven't talked about yet would be NT-proBNP, which is a cardiac biomarker. If you have disease processes that are concurrent, like renal disease, this is going to be potentially falsely elevated. But there are a few studies looking at dogs with degenerative valve disease and kind of what kind of line in the sand for a value for NT-proBNP would be more indicative of stage B2. And what this cardiac biomarker is looking at is mainly kind of cardiac stretch. And so that line in the sand is around, if it's greater than 1500 picomoles per liter, that would be a potential additional tool that you could use if you didn't have thoracic radiographs or echo. Just keep in mind that every test has kind of their limitations, right? And so you could get a false positive and have that be falsely elevated. And then again, are you kind of using pimobendan before you would need to? That's not on the label for pimobendan, but I think that I would rather kind of have maybe murmur plus using a cardiac biomarker versus murmur alone, if that makes sense.
Yeah, yeah, absolutely. Any additional information we can get to guide these clinical decisions and make sure we're doing the right thing.
Yeah.
Yeah. Well, we've talked about that approach to a new murmur. And of course, a lot of these patients, they're asymptomatic when we first diagnose them with the murmur. I'm wondering how your approach to treatment would change for a symptomatic patient, the coughing dog that comes in, as opposed to an asymptomatic new murmur diagnosis.
Yeah, no, I think that's great. I think one very important thing to remember is I think sometimes we think about stage B versus C just being like symptoms or not. And I think where the gray zone can be is that coughing dog that maybe is not in respiratory distress, is, eupnic at home, but it has a new cough. And I think the biggest thing to remember there is that they could be coughing for a majority of reasons. And so I think the best thing, how to proceed with kind of that coughing dog, one is getting a really good history from the owner. So is this cough maybe over the last few months, or is it really just started yesterday? What's the characteristic of the cough? So is it more like, dry and hacking cough or a honking cough, like you might suspect tracheal collapse? Versus is this just a new murmur that's kind of more soft and wet? And I think for that kind of chronic cough that's maybe more dry sounding, more honking, that's kind of my suspicion for other reasons, primary respiratory reasons or airway reasons for cough is higher. Really, the best thing will be to take chest radiographs and then see if there's any evidence of cardiogenic pulmonary edema. So that's one reason they could start coughing if they were progressing to heart failure. In that patient, I would look for, seeing if those pulmonary veins are distended. You should have cardiomegaly at that point. So VLAS and VHS are elevated. And then this kind of unstructured interstitial pattern. Another reason that a dog may cough that you can catch on radiographs would be if they do have left ventricular and atrial enlargement and that left atrium's kind of pushing up on that main stem bronchus. I think that can also be a quite common reason that maybe they're still within B2 dog would cough without being in heart failure. And so, yeah, my approach would be to take chest rads and then really trying to decide, are they in heart failure or not? Because that's kind of when you go into using diuretics and RAS blockers and things versus if they are not in heart failure and there doesn't seem to be overt main stem bronchus compression, maybe you are going down more diagnostics for chronic bronchitis or other primary respiratory diseases.
Yes, that enlargement, pushing up on the airways up against the spine or collapsing trachea are like just my nemesis. And these little tiny guys that are coughing and they have a heart murmur. And I'm like, oh, why are you coughing? And
Why? Yeah.
look at these x-rays and I'm immediately filled with self-doubt of like, is it more opaque or is it just inspiratory and am I missing something? It can
Yeah.
be such a challenge. But I love that you bring up, look at the VLAS, look at the vertebral heart score,
Mhm.
look at the pulmonary vasculature and be aware of collapsing trachea and main stem bronchi and everything like that and put the whole picture together rather than just the pulmonary pattern in and of itself. There's a lot of indicators here that we can piece together to help figure out where that cough is coming from.
Yeah, and one tool that I, right or wrong, I lean on in my practice is the information from the owner on even the resting respiratory rate. Because say it's that patient that you were describing, it's so frustrating, you're not exactly sure, maybe they have a big heart, maybe there is mainstem bronchus compression, but trying to figure out failure or not if there's subtle changes in the lungs. Sometimes I will, and the patient is sitting in front of you looking, eupnic and pretty good. I might actually even have that owner go home and get a few like sleeping respiratory rates for me. And if their sleeping respiratory rate is normal, so kind of for me that like 35 or greater, I'd be breaths per minute, be more worried. But if they email me the next day and they're like, hey, the resting respiratory rate's 20, then my suspicion of heart failure is much, much, much lower. So that can also be a little tool to use.
That is a really good recommendation. And I think is kind of some reassurance to, if we look at this patient and our clinical judgment says, we've got a little bit of time here. These lungs aren't filled with fluid. This patient is not in respiratory distress because inevitably they come in at like 1:30 on a Saturday when you
Yeah.
close at, 2:30 and you're going, oh, shoot, I got to leave you for the weekend. But to say, hey, this is a tool that you can use to know when you need to seek additional care. And especially if our clinical judgment is telling us we have that 36 hours or so to give the owner to say, all right, let's keep an eye on this. And then if we have that indication with the signs you're seeing at home, in addition to what I'm putting together here at the clinic, then we can go ahead and assume this is heart.
Yeah.
These are all such good practical, like put the pieces together. And I think it's such a good reminder to remember all the individual pieces of information that we have rather than just, chest x-ray, vertebral heart score, yes or no. There's a lot of different pieces of those radiographs that we can look at and having the intensity of the murmur and the owner history and the resting respiratory rate, we can really put this together nicely to make good clinical decisions.
Yeah, and one additional little fact is I think if you see that older small breed dog and we get referrals for this sometimes too, is maybe someone has ausculted like crackles on auscultation of the lungs. If that patient, like using your tools like you're describing, if that patient doesn't have a heart murmur and it's a small breed older dog, I think the suspicion for, oh, this is heart failure causing these crackles, your suspicion of heart failure should be very low in that patient because the majority of these small older dogs are it's going to be mitral valve disease if they have significant cardiac disease. And so with no murmur, even if you're hearing crackles, I think heart failure should still be pretty low. And so, yeah, interestingly, we'll see kind of some patients that maybe they get referred for, okay, we're worried this could be heart failure, but just to recognize there could be other reasons for like pulmonary fibrosis can cause crackles or other reasons for crackles. So off topic, but could maybe be helpful.
I think absolutely helpful if our primary differential is mitral valve disease to say, well, if we don't have other signs of mitral valve disease like this dramatic murmur, then we should just make sure we're checking the boxes in these other areas as well.
Totally.
Well, we've talked about the financially constrained owner, but I'd love to also talk about the very motivated owner because, kind of like we alluded to in the beginning, big things happening in cardiology. I'm a Gator, and so our open heart surgery program is in full force here, which is something, honestly, I have to figure out more about it. I have not had any patients referred through that program to know enough about it to speak in an educated manner, but just a lot more options than we've ever seen before in veterinary cardiology. So, what's your approach to the very motivated pet owner?
I think that's I mean, I see these types of owners quite frequently, or they'll reach out to us. I think it is an exciting time in veterinary cardiology because we have been for so long managing these patients medically. And if you are a human with this disease process, they would be reaching for kind of a surgical mechanical fix to that leak. And so it's exciting about now in veterinary cardiology is that we do have a few options for kind of reducing the mitral valve regurgitation. One that you mentioned is kind of open heart surgical repair of the valve. And yes, University of Florida has a current center. And then there are some kind of international centers in the UK and in Japan, with many of those centers having extensive experience in repairing the mitral valve. So one important thing for you to know is we're probably not going to reach for open heart surgery when they have very, very mild disease, because many of these patients can tolerate this disease for a very long period of time. Once, they have a closer to grade 3 out of 6, or if they're motivated, maybe they go get that echo before. But we really wouldn't be recommending these more surgical fix till they're probably in stage B2 or C. So that's kind of one piece of information. And then a newer technology or device that can be on your radar is that we at CSU here have some kind of earlier experience. We're on our over 100 cases of called the V clamp. So it's an edge-to-edge repair. So it's a beating heart procedure where we use a device. We insert that device from a kind of transapical approach. So it does require a little thoracotomy. And then we are clipping those mitral valve leaflets together in the center of the valve to reduce the leak. And we have very strict criteria on kind of who is a candidate just from an anatomy standpoint of their valve for that procedure. But I think that's just an exciting time for us to have kind of multiple things that we can pursue for these dogs with mitral valve disease. So I think for you, if it was an owner that was very motivated, I think have them connect with a cardiologist and kind of hear all of their options, get that echo, confirm the diagnosis, and kind of then have a monitoring plan so that the intervention can happen kind of when it's indicated.
And it's interesting. Like I said, I'm not familiar enough with the open heart surgery program to really comment on it. That you said, stage B2 to, approaching stage C, because that's been one of my questions since I heard that open heart surgery was available, is prognosis for these patients after surgery. But it sounds like what you said, if we're not intervening so early that we're putting these patients through an unnecessary procedure when they might never progress to failure.
Right.
But intervening at stage B2 early C seems early enough that we can actually probably buy these patients a pretty decent prognosis. Is that what your experience has been with the V clamp technique?
Yeah, I think we're still learning a lot with the V clamp, which is great. We're kind of collecting data on every patient we've done, kind of longer term. Speaking on mitral valve repair, really their hope with that procedure, and I don't do that procedure, so can't speak with certainty, but their hope is that they can sometimes get these patients off cardiac meds and really hopefully stabilize their disease for years to come, depending on the age of the patient. I think the V clamp, it's more limited on kind of the actual intervention that we can do to clip the leaflets together. I think though for us, what we're realizing is that if we intervene at the right time for the right candidate, it also can be game changing in terms of, we can't stop the degeneration of the valve, but can we really set that clock back to where maybe they were going to go into heart failure within the year, but now maybe we're setting that clock back by a year or two. And I think, yeah, we can't yet speak to efficacy until we have that longer term data, but that is kind of our goal, is intervene when we're convinced that they're going to need it in their lifetime, and then hopefully giving them more quality time with their pet.
Gosh, yeah, especially when you talk about potentially being able to take them off of medications in some of these cases. I mean, that can really create some quality of life for these pets and pet owners.
Right.
Cardiology is so cool, and all these advancements are
I think so
so
too.
exciting. Yeah. Yeah, I would. Well, good. I'm glad that you think that, and you
Yeah.
can hear your passion and your knowledge come through with all of this. I've always felt that way about pacemaker cases, is, these third degree AV blocks come in. I remember that from working in anesthesia before I went into vet school. And it was like, then this pacemaker would be inserted, and it was like,
Game
just this,
changing.
yeah, miracle. And then,
Mhm.
these dogs would walk out not very much later after that procedure and
I
just
know.
do phenomenally.
Yeah. No, it's a fun time. And I think, we could talk 10 years from now, and I think there's going to be a lot of new information. So it's exciting.
What a time. What a time to be a
I know.
veterinary professional.
Right.
Uh, well, Dr. Potter, thank you so much for joining me. This has been a really helpful talk in terms of just how to think about these murmurs and how to put the pieces together to make good decisions for our patients. So I really appreciate you joining me and for all of the information.
Absolutely. Thank you guys for having me.
Well, I don't know about you, but after this conversation, I certainly feel a little bit more comfortable about that nuanced approach to a new murmur than I did before this conversation. I want to say a huge thank you to Dr. Potter for joining me. She was absolutely lovely to speak to. Thank you for all of the wonderful information. Big thank you to Boehringer Ingelheim Animal Health for making this episode possible. And of course, thanks to all of you for joining us. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. I am told that it will help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, click on the Education tab on the Vetfolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassie DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day.
Vetmedin CA1 Pimobindin chewable tablets. Important safety information. Vetmedin CA1 Pimobindin are for use only in dogs with preclinical MMVD that have a moderate or loud mitral murmur due to mitral regurgitation and cardiomegaly, stage B2 MMVD, 2019 ACVIM Consensus Statement 1. Vetmedin CA1 is conditionally approved by FDA, pending a full demonstration of effectiveness under application number 141-556. A diagnosis of MMVD should be made by means of a comprehensive physical and cardiac examination, which should include radiography and echocardiography. The most common side effects seen in dogs with stage B2 MMVD while taking Vetmedin CA1 chewable tablets are cough, vomiting, diarrhea, lethargy, and localized pain, such as in the neck or legs. Adverse reactions not related to disease progression in dogs receiving Vetmedin CA1 included diarrhea, vomiting, pain, lameness, arthritis, urinary tract infection, and seizure. For more information, please see full prescribing information or visit vetmedin.com. Do not administer Vetmedin CA1 to dogs with stage A or B1 preclinical MMVD, 2019 ACVIM Consensus Statement. Due to the risk of cardiac pathology associated with exaggerated hemodynamic responses to Vetmedin CA1. Vetmedin Pimobindin chewable tablets. Important safety information. Vetmedin Pimobindin chewable tablets is for use in dogs with clinical evidence of heart failure only. The most common side effects reported in field studies were poor appetite, lethargy, diarrhea, dyspnea, azotemia, weakness, and ataxia. Vetmedin should not be given in case of hypertrophic cardiomyopathy, aortic stenosis, or any other clinical condition where an augmentation of cardiac output is inappropriate for functional or anatomical reasons. For more information, please see full prescribing information or visit vetmedin.com.